Okay, good morning, good afternoon, good evening, everyone, and welcome to our webinar series. It's great to have you here in this session, all our speakers as well as participants. And I can see names that I have seen in the previous webinars. So thank you for continuing to participate in this important webinar that we've been hosting in collaboration with the Johns Hopkins Bloomberg School of Public Health. And my name is Frey Hiwet. I'm the Executive Director at the International Institute for Primary Healthcare in Ethiopia. And it's been since January we started hosting this webinar series by anchoring different topics, loosely anchoring different topics in the PHC framework that WHO recently, shared. And it has been an exciting journey. We have learned a lot from our speakers, a lot of insightful questions and future recommendations were being proposed in the Q&A session during those series. And today's topic will be discussing a very important element of primary healthcare, which is digital health. And I think it's key to really discuss and strengthen digitization, especially when we speak about future of PHC. So without further ado, let me hand it over to Dr. Micah Schleif from the Johns Hopkins Bloomberg School of Public Health to introduce our moderator. Thank you and welcome again. Over to you, Micah.
Thank you, Dr. Freyhiwet. Greetings, everyone. Welcome. Very, very exciting to have this session. And I'm Dr. Micah Schleif. I'm a faculty member at the School of Public Health and lead the collaboration with the International Institute for Primary Healthcare from the Hopkins side. So it's a pleasure to be here. And it's a great pleasure to introduce a colleague and a friend, Dr. Smisha Agarwal, who is an assistant professor also in the Department of International Health at the Johns Hopkins School of Public Health. And I'm really excited to have her as a moderator today because I think that she comes from a really strong background of working in and with communities and seeing primary healthcare in action, both as a clinician, but also as someone working really on community empowerment, community engagement, and figuring out what we need to do at the community level to support primary healthcare systems, and then also brings this really strong perspective of the potential of digital health and how we can use that to connect with people, to improve data, and to really facilitate the work that we're doing through public health and health systems. So thank you for moderating this session, Smisha, and I'll pass over to you.
Great, wonderful, and good morning, good afternoon, good evening, everyone, and welcome to this session. So I think over the last nearly 2 decades of working at the intersection of digital health and primary healthcare, I've seen almost this divide where there is a group that believes that is enthusiastic and believes that digital solutions can really address several of the barriers we face in primary healthcare and health systems. And we use the term leapfrog. It can jump over those challenges of lack of infrastructure, roads, electricity, because we found solutions by which we can make healthcare accessible remotely through mobile phones to communities. We can use it as a training tool for healthcare providers. We could use it to follow supply chain systems and to see where commodities are needed and how they can be made available. And I think over the last several years of the SARS-CoV-2 pandemic, we've seen that when in-person services were not possible, digital tools provided a way to connect communities and to connect individuals to the healthcare system, either through telemedicine or through a variety of innovative measures. So there is definitely tremendous potential. I think we've also met a number of folks who are very skeptical, who worry that when countries and situations are lacking basic health infrastructure, will investing in digitization detract from the development of essential services? A very valid concern, because in a lot of places where we work, there aren't those basic healthcare services. Can digital tools actually leapfrog over no availability of providers, or through poor skills or training of healthcare providers? And so those questions and those considerations, I think, persist. So to add to sort of this debate and think about how can we implement digital solutions in a way where they are not just a solution, where digitization is not seen as the whole and the soul of a program, how they can be incorporated as part of a larger program, where we are recognizing that taking a health systems approach, that is system-wide approach, of which digital is one portion of a larger solution, how that might strengthen healthcare systems. So we have three panelists with us today. Tigist Tamrat, who is able to provide a sort of global perspective from the WHO and has really been instrumental in guiding several of the in developing several of the guidelines and critical resources in digital health today, and Dr. Farzana Misha and Dr. Loko Ibrahim will bring perspectives more specific to Bangladesh and Ethiopia. So we'll have a number of different perspectives. We welcome questions or thoughts, reflections in the Q&A, so that we can keep this discussion, we can keep this as a discussion. I will pass on to our first speaker first with a brief introduction. And so it's an absolute pleasure to introduce Tigist Tamrat, who's a technical officer at the WHO based in Geneva. Her work focuses on digital technologies. If you've worked in digital health, chances are you've leveraged something that Tigist has developed. She's coordinated the design and impact of digital health tools, implementation of digital health tools with the WHO. She led the WHO guidelines on digital interventions for health system strengthening, and several really important tools that exist out there, including the classification of digital health interventions, the digital investment implementation guide, MAPS toolkits. I'm going to actually add links to those resources that Tigist has developed in the chat, so that I think they're excellent resources for folks who are looking for a guide on how to. And Tigist has most recently been working on the WHO SMART guidelines. Tigist, I hope you'll be able to talk a little bit about that, and which includes digital adaptation kits and the concept of computable guidelines. So welcome, Tigist, and over to you.
Thank you very much, Smisha, for those really kind words, and yes, and for that introduction. And indeed, I think a lot of the words that you said at the beginning resonate with how we at WHO have been trying to address how we deal with digital health interventions, especially when at the critical primary healthcare level. So maybe just taking a step back, when we try to conceptualize, how can digital health actually contribute to the PHC goals? And to Smisha's point, I think we really have to be modest about what digital can do and what, other types of interventions will have to come in. But broadly speaking, the areas where we think that digital health could have an impact is there are interventions that we know of known efficacy. So for example, that there should be 8 ANC contacts, or that there's certain contraceptive methods, or screening for hypertension, or whatever the actual health condition is. We know that there's an evidence behind it, or as WHO, we try to work on the evidence base to improve those types of health conditions. But we often realize that there's a lack in the quality or the coverage of that health intervention. And so it could be that people aren't able to access the recommended interventions, the recommended health interventions, or it could be that they're done with poor quality, and also just cost as well. It's not featured here, but we realize that potentially digital health, and especially, with the novelty of mobile devices, could help to maybe expand coverage. So helping to address what we consider health system challenges, such as poor demand for services or not being able to access services. So that's where things like telemedicine can come through to be able to overcome barriers to accessing health services, as well as things related to quality of care. And maybe there's a way to reinforce the guidelines. Obviously, as Smisha said, this won't overcome the challenges of, not having sufficient health workers, but perhaps there's a way that we could mitigate some of those challenges. And a lot of the challenges and issues that Smisha already spoke about in her introduction, we think, oh, is there a way? We have this hypothesis. And over the past years, we've been trying to work at how can we first assess the evidence of this, which is what we did in the digital health guidelines. And we saw that there was not as, for all the enthusiasm, probably not as solid of an evidence base to support this. But we do also realize that in some areas, this digital may be the only way to actually provide access to services, or that we can't actually ignore that digital health is going to be around, and we're very encouraged by the high penetration of mobile devices, et cetera. And so, we've put forth these recommendations knowing that there's a lot of implementation questions, a lot of operationally how you put this into place is going to be challenging. And following to that, we recently released the Digital Implementation Investment Guide, which is, okay, how can we systematically try to, introduce and implement digital health interventions in such a way that we can really try to maximize the benefits from it. So trying to make sure that we don't make the same mistakes as other implementations, and really trying to make sure that we've checked all the boxes that we could as much as possible. So this is just the overall background to where we are at WHO. And one of the things that we also realize is that digital, there's a lot of excitement around digital tools. And one of the key features of what WHO does is developing guidelines, not just guidelines on digital tools, but guidelines on, HIV, like what should you do for PMTCT or EMTCT? What should you do in the case of antenatal care? When do you refer someone? And this is really the norm setting function that WHO has. But we realize that a lot of times when you release these guidelines, they're very difficult to operationalize because, they use a lot of vague language maybe, and that's just because of the way that we have to try to find consensus when we're trying to develop guidelines. But when it comes operationally, at the primary healthcare level and interactions with patients and individuals, it's very difficult to go back to what WHO may have published on its website. And so we're really trying to figure out how could digital tools be a way to help be a channel to reinforce the WHO guidelines at the point of care. And we see, this is a photo of someone at the point of care in a primary healthcare setting probably, and has so many documents to sift through. And how could we use digital tools to help, maybe through decision support, through training, through, e-learning and learning types of packages, how could we use that? And oftentimes when people do try to take WHO guidelines and turn it into a digital package, they have a lot of questions. Even when we are trying to do it at WHO, we have a lot of questions and have to go back to the person that developed the guideline and said, when you said young people should not use this contraceptive method, like, what did you mean? What does young people mean? What is the age cutoff? And all these questions, because when you go to a digital platform, you actually need to have the specificity and you need to have it concise. And it's very difficult to do. So WHO kind of has been realizing that we need to support how countries are digitizing and how they can make the best use of the guidelines, of the clinical guidelines that we put out. And we realize that in the absence of this, guidance on how to digitize with WHO guidelines, we realize that a lot of people have just been kind of doing their own things, not maliciously, but just because you have to create a digital system, vendors are under obligations and someone asks them, please develop me a system for antenatal care. You may go to the WHO website, you may confer with, some technical leads, but you don't actually have a blueprint of what should you do, what data elements should you include, what should the algorithms look like. And so this is what helped to launch the SMART guidelines with our chief scientist, Dr. Sumya Swaminathan, is how can we create tools that are software agnostic, so not necessarily promoting a software application itself, but how can we deconstruct our guidelines, retain the document as it is, because there's some use in that, but how do we distill it in a component that can make it easier to digitize, as well as maybe potentially also computable, so that you can just download code content and you don't need to go and read through pages of guideline recommendations. So I won't go through this in too much, but just to say that SMART guidelines is actually an umbrella term, and it has many different components. And the way we conceptualize this is that we start with our the guidelines, the narrative form that a lot of you may be familiar with. And these are the PDFs, they're the books, they're the authoritative material on a specific health topic. And what the next component is what we call digital adaptation kits. And I'll go into that a little bit more as a focus for this presentation. And it's really taking it and putting it into what we call human readable. So it's still readable by us individuals, but it takes the guideline and puts it into components that, software developers as well as health program leads would understand. And then going along the progression of the SMART guidelines, we also have what we call computable, and that's actually providing the guideline content in code format so that you can just download the code and, incorporate it into your digital system. And that's where a lot of colleagues in the Digital Health and Innovations unit are really focused on trying to figure out how can we package this so that it's not even just for humans to read, but it's actually for digital systems using standardized data exchange language to be able to just take in the content. So WHO can issue a recommendation on, say, certain treatment, and you can just push a button and then you can just download it. You can download the code and it will give you the algorithms. And then we also think about the application itself. So this is what a health worker would see, at the point of care. And there's less of a focus increasingly on WHO releasing applications. I think there's a recognition that there's a lot of stakeholders and implementers that can really create software really well, and that our focus should really be on the health content and trying to make sure that that health content is easily accessible and digestible for digital systems. And then eventually thinking about, it's inevitable, I have to think about AI and advanced analytics and machine learning, and how can we standardize all this information in such a way that we can contribute to better predictive analytics for public health purposes. So just to emphasize, when we think about how digital health implementations are comprised, we think, first of all, that there's this foundational layer of leadership and governance, the strategy investment, the applications, we'll talk a little bit about those, but the legislations, the workforce training, the infrastructure, the connectivity, the interoperability, these are musts that you need to have, and they're well defined in the WHO eHealth strategy toolkit. But on top of that, you have the specific digital tool, the tangible tool that, say, a health worker would see. And that is comprised of like the actual software application. So that could be ComCare or Medic Mobile or OpenSRP or DHIS2 Tracker. This is the actual application. And within that application, you can have different types of health content. You could have a ComCare tool with ANC content, and you could have a Medic Mobile tool with an ANC content, or you could have family planning on Medic Mobile. You could have a variety. So we try to tease out that there's health content. And for us, the health content is paramount. That is really where we want to make sure we don't care what system you're going to use, but we really want to make sure that that health content is derived from an evidence-based source from WHO's guidelines. So we've released these things called digital adaptation kits, and they're software neutral. So they're in the formats of spreadsheets. It's not an application, but they're structured ways of distilling WHO clinical and data use recommendations in such a way that you can then think about, okay, how do I program this into my digital system? And they're generic because they're derived from WHO guidelines. So there's a lot of questions that we get. Well, in our country, we've adapted the X guideline and we don't, our cutoff for anemia isn't this, it's X. And that's fine. We expect that, 80% of it could be consistent, and that as different countries have different policies that they've adapted. One example is in certain countries, they have different immunization schedules, or there's some immunizations that are recommended and some that are not. And we go with what the recommended package is, and then countries have the opportunity to adapt. And then this is also a way to really bring in the different contributors, from the programs, from the digital health side, to really talk about what is going to be in our digital system. And within a digital adaptation kit, we have 8 components. And so these are what you would need to, as part of what we call a requirements gathering process, when you're trying to define what should go into designing a digital system. These are what we've determined as the 8 key ones. So, knowing what the health interventions are that you're going to include in the digital system, knowing who it's for, what roles do they have? Is this for a nurse midwife? Is this for a community health worker? And, what are their responsibilities? How do they interact? What are, some of the scenarios of use? Keeping in mind that we can't be exhaustive. And then what is a business process workflow? So this is roughly to say, how do they interact on a visual level? So, someone enters and someone's registered, and then someone waits in a queue, and just really putting this down in a visual format that both software developers as well as health program leads can understand. And then understanding what's the data that's needed. We know that a majority of primary healthcare workers, they need to be compiling reports from the registers and submitting that. And what do they need to record, linked to either guideline recommendations, so to make sure that they're, doing certain services, as well as there may be aggregate reporting needs that they have. And so we put a recommended data elements package for that. And then the decision support logic. So this is really going to our guidelines and saying, okay, if a woman has preeclampsia, or if a woman has blood pressure above X and she's showing X symptoms, then, refer to this. And that is really deconstructed, and I'll show some examples. And then indicators and monitoring, we just take this from existing resources. So they need to report on ANC1, ANC4, and we just try to link it back to data elements, and then functional, non-functional requirements. So this is just, what a workflow would look like, and it's really intended to help with that design process and really catalyze like the thinking about how the digital system would be developed. And then this is really like how we present it within the digital adaptation kit. These are the key core data elements. If you're providing counseling on family planning, you need to know if they're breastfeeding, you need to know any past issues or anything like that, so that you can recommend the appropriate method. And then we actually provide a data dictionary with all the responses, linked to ICD codes. And this is really what's missing from the guidelines, is how do you operationalize all these recommendations? And then this is how we provide the decision support logic. So, if someone said they wanted a copper IUD and they have a health condition of irregular bleeding, this is, how it would be represented, really distilling it. And I'll go really quickly. For the sake of time, this is what a text from the guideline looks like, and you're like, okay, how is someone at primary healthcare supposed to really make use of this? So we then say, okay, what we need, this is the input, this is the output, this is what you need to put in your digital system. And this is what it would look like if it's computable. And then this is what the health worker may actually end up seeing on their interface. So just to walk through. I'll just skip through just to say that now we're in this process of how do we, we've developed digital adaptation kits for HIV, for family planning, for antenatal care, and there's many more across WHO that are being developed. And the question that we have is, how do we actually apply this and incorporate this into PHC? What's the contextualization needed? How do we do this? What's the process? And we're maintaining a software neutral approach. So we're not actually bringing in an application, but we are trying to bring these spreadsheets, and how do we actually make use of it, and what's the resulting impact? Are we really able to move the needle on service delivery and quality of care and data flows by having provided this type of documentation? So I'll stop here, and really grateful for this opportunity, and I look forward to any questions from the group. But thank you.
Great. Thank you, Tigis. That was really, really insightful. Maybe I'm seeing some of the comments in the chat, and maybe one clarification I can offer before we move on to our next panelist is one of the challenges we see in the digital ecosystem is investing in creating a digital system can usually take a lot of time and can take a lot of resources. It can also result in a lot of fragmentation. I'm sure we might have heard that, you know, a different system is being implemented in one district, a different system in the second district, sometimes two or more systems in the same district, right? Which can result in a lot of confusion. So there are sort of globally a few recommendations. One is that we're thinking about this overall what system is being implemented in the district. But the WHO's efforts towards the digital adaptation kits is really to accelerate the pace of research. So instead of every developer trying to translate the narrative guidelines into digital guidelines, now with these digital adaptation kits, a developer might be able to take those, and these are already in a format that's easy to sort of ingest into a digital system, put a front end. So a front end is like an app that somebody can place on top of it, but the digital system's ready to go. So it can really expedite the process of going from concept to implementation. And it can also reduce the resources and the technical skill set required to do that. So that's really an incredible opportunity with that. Tigust, I hope that was an accurate representation.
No, that's perfectly correct. Thank you for adding that.
Great. So we can move on to our next panelist, Dr. Farzana Misha, who's an assistant professor at Brack James Grant School of Public Health. Dr. Misha is an applied economist with over 12 years of experience in impact evaluations, has a lot of work on social safety nets, health, digital and financial inclusion. She uses a multidisciplinary approach in her work with economics, behavioral economic theory, public health, and impact evaluation, and has more recently been engaging in the digital health space, especially around financial inclusion services amongst the vulnerable and hard to reach. So welcome, and look forward to your presentation.
Thank you, Smisha. Hi, so today I'll be talking about digitizing primary healthcare in the context of Bangladesh. So, so first, what do we understand by primary healthcare? So I'm sure we all know, but I'm just highlighting some lines from Declaration of Alma-Ata 1978. So it's basically essential healthcare based on practical, scientifically sound, and socially acceptable methods and technology made universally accessible to individuals. And not to mention, this is the first level of contact of individuals, community, and families with the national health system. So now I would like to give you an overview of Bangladesh's health system and performance so far. Bangladesh has made impressive achievements, and since its independence in 1971, we have been successful in increasing life expectancy, reduce under 5 mortality rate, and also the total fertility rate. And much of this success has been attributed to the country's focus on gender equity, increased access to education, and also health intervention targeting RMNCH and infectious diseases. However, there are still some concerns when it comes to Bangladesh. For example, the maternal mortality ratio is still higher than its neighboring countries. And then there is recently Bangladesh has been facing this double burden of malnutrition, where we see high rates of children with nutritional deficiencies. But then again, there's an increasing rate of overweight and obese adults. And also there's a growing burden of non-communicable diseases. And this is partially driven by urbanization, aging population, and all underscoring the need for strengthening and adapting primary healthcare. So why digitize primary healthcare? First of all, digital healthcare services has the potential to reach or transfer health system in low resource settings like in Bangladesh and ensure effective and fast healthcare delivery. And one big example we've seen during the COVID-19 pandemic that it's doable, and especially it also can help you access the marginalized populations, and especially criminalized groups in some countries, like people living with HIV, migrants, LGBTQ population, etc. So a quick overview of Bangladesh's digital health journey so far. Bangladesh is still taking baby steps. However, the journey started in 1999, but till 2009, it was mostly telemedicine services provided by, on a limited basis, provided by some private health service and private organizations like Grameen Telecom or Grameen Communication. But the big push came in 2008 when the current government declared the Digital Bangladesh and Vision 2021. And right after that, in 2009, Director General of Health Services, DGHS, introduced District Health Information Software to DHIS2 to collect information. Then in 2015, we have this Shastawatan was introduced by the government, a national health call center. And finally, during the pandemic, the government launched the Shurokha app for COVID-19 mass vaccination. And that's vaccinating 160 million population, and it was a big success so far. So now just to give you an overview, because Tamrat mentioned legislation, policy, and compliance. So in terms of legal and political framework, where do we stand in Bangladesh? So the Constitution, as per the Constitution, health is a fundamental right, and it also aims to remove a disparity between urban and rural. There's a reason why I think urban and rural, we'll talk about that later. Improve public health and nutrition status, and ensure equal opportunity for all citizens. In terms of laws and policies regarding health and digital health, under the National Health Policy, it does recognize, urge to increase e-health and telemedicine and other digital-based health services like electronic public awareness campaigning, e-governance, etc. However, under the population policy, the only place where they mention digital is for collecting information, nothing on implementation strategies. However, for National ICT Policy 2018, it explicitly mentioned digital health services, where it includes portable electronic health records, clinical decision support system, even massive open online courses for health professionals. And interesting enough, it also mentioned augmented reality, AR, and virtual reality, using these for nursing and midwifery education. So now, just to give you an quick overview of health system, so that we can see how in different stages of the health system, digital health has been implemented and how they're performing. So the Bangladesh health system, what we can call is fragmented. So it is governed by Ministry of Health and Family Welfare. However, the Ministry of Local Government and Rural Development plays a significant role when it comes to urban areas. So the rural area health facilities are under DGHS, the Ministry of Health Services, Health and Family Welfare, whereas for the urban, it's under LGRD, which, as you can imagine, it becomes a bit complicated when two ministries are trying to work together. And so this is to give you an idea how this is. So, and in terms of services, as you can see from the pyramid, the primary at the village, union, and sub-district level, only primary healthcare is provided, whereas for the secondary and tertiary provided in the district and division level. So if you're living in a union and you require secondary services, you have to access the district level hospital. And union level and ward level hospital clinics and community clinics, they provide PHC services to medical doctors and community health workers. So now coming to DHIS2. So apparently Bangladesh is the largest DHIS2 deployer in the world. Impressively, this system now connects central, divisional, and district level with sub-district health facilities and over 13,000 community clinics. However, most urban health facilities in Bangladesh are not reporting to DHIS2, and this is because of a 1982 ordinance. Under that, private hospitals and clinics are not obligated to share information with the government or the health ministry. A change was made during the first dengue outbreak that happened in early 2000, under which they were obligated to share information regarding infectious diseases. And that was very useful during the pandemic, as you can imagine. The DHIS2 is also largely dependent on international donors. So the sustainability is the question. It lacks in critical information such as family planning statistics. And also DGFP, that's the Director General of Family Planning, and DGHS, the health system. They maintain parallel HMIS, which creates a number of issues, including double counting and non-accountability of service outreach. And it makes it difficult to measure impact of any government intervention, health intervention, or public health intervention. There are a number of digital health services available at this moment, apart from the DHIS2. So the digital health informations are provided by NGOs, government, and private organizations. And there was a exponential increase, as you can imagine, during the pandemic. So these services, they mostly provide audio-video consultation or information, and services such as like collecting samples from home, providing test results using digital platforms. However, these digital platforms, most of them, they lack authenticity and accuracy of information provided. Some of them are seen to reaffirm common myths and misconceptions regarding sexual and reproductive health and rights. They also lack language options, so either it's English or Bangla. And they also lack interactive tools. I remember Tamara talking about the apps. So some of these apps, as I've seen, they are not very interactive. So after a while, the users, they lose interest and they are not using that anymore. And also they lack, they only have options for binary genders, so excluding people of other genders from the very beginning. So now I'll just go to some bottlenecks and possible recommendation in terms of policy and regulations. Bangladesh, as yet, we don't have a national e-health strategy so far. Even though Bangladesh has been working, DGH has been working on a draft national e-health strategy since 2020, but it's not out yet. Data sharing mandate between public and private health service provided, as I mentioned, in 1982 ordinance. So that needs to be updated to have a like a full picture of the status in terms of public health PHC. And also regulation for digital health startups, it's absent at the moment. So anyone can start a health app and provide any kind of information or services. In terms of data management, there's a lack of unique ID for children because the current unique ID, which is the national ID, excludes children under 18 years old. We can think of birth registration, but the current birth registration system is quite complex. It requires a number of documents that makes it even more complex. And also there's another issue is use of universal terminologies. So what happens for DHIS2, suppose in different districts, while data input, like entering data, the use of different terminologies can make it difficult to merge all these data sets together. For example, maybe in one district, they're using TB for tuberculosis, but in other, they're using tuberculosis, and in another district, they're using tuberculosis, but with the wrong spelling. So when you want to merge all of them together, it's difficult. In some cases, it's very time consuming. Capacity development, digital literacy, that's something we need to work on, especially for field level health staff. Capacity development for IT staff is also required. Bangladesh have union digital centers at the union level. Every union has a union digital centers, but they're accessing health information, even for birth registration and any kind of using digital platforms or in any help. From our previous studies, we've seen that it can be difficult. So that's one thing. And DHIS training curriculum should be tailored to meet the needs of health professionals from different levels. And simultaneous refreshing trainings are also needed. And two last points. One is effective content creation. So the union and world level, the government clinics, they do show videos to increase awareness or disseminate health information, where to go for vaccination, etc., for reproductive health. But these videos, the contents are not contextualized, so those they are created for, sometimes they are unable to absorb the information. And last but not least, sustainability of the digitization, digital health system. Because so far it's dependent on international donors, but funding generation through public and private partnership can help sustain it in the long run. Thanks a lot. That's all from me. Thank you. I'll stop here.
Great, thank you, Dr. Misha, and also appreciate being very sensitive to time. It's a very comprehensive overview that you're able to provide. I think there were a few sort of common themes that, or I think challenges that you identified in your presentation that are sort of intended to be addressed through the adaptation kits, the digital adaptation kits that Tigist mentioned. I think one of them was the use of universal terminologies. And so sometimes we talk about the concept of interoperability, where if we are not using, we say semantic interoperability, if we are not using standard terminologies, it's not possible to share data between systems. And one of the efforts of the digital adaptation kits is recommended. So if you look at, I sent a link for the digital adaptation kits, but it has identification of the data elements and the definitions of the data elements that a digital system record. And so that's one attempt at systematizing the terminologies. Tigist, do you want to add something over there?
Oh, no, I just turned on my camera.
Okay, great. And then I think there were other issues that you highlighted that are really critical from my perspective around policies and regulations, not having a cohesive e-health strategy nationally. I think lack of unique identification for children under 18, specifically in most other countries, lack of unique identification in general are some critical pieces that I think really limit the use and the potential of digital tools. So yeah, appreciate that and look forward to further discussion on that. So I'll turn over to our last presenter, Dr. Loko Abraham, who is the Chief of Party for USAID Digital Health Activity in Ethiopia. The USAID Digital Health Activity is a critical partner of the Ethiopian Ministry of Health and Health Systems in health information systems, and it supports digitization of health information systems, including primary healthcare systems, as well as generation and use of quality data, and to build capacity of health workforce to improve competence and sustainability. Previously, Dr. Abraham served as the Director General for Ethiopian Pharmaceutical Supply Agency that supported supply chain management for about 80% of procurements and distributions in Ethiopia. And he also served as a Chief Executive Director of a teaching hospital. He received his MD from the University of Gondar and has specialized in child health and pediatrics from Addis Ababa University. So welcome, Dr. Abraham, and look forward to this discussion.
Thank you very much for the opportunity again. So I'll try to be brief and give a very high level context of where Ethiopia as a country is in terms of digitizing the primary healthcare and beyond. So, you just mentioned how it's important to actually frame and have political buy-in in inclusion of digital health intervention at the national strategy level. And I think the Ministry of Health in Ethiopia has taken a bold step in making sure that digital health intervention is properly highlighted in its strategic document. Ethiopia is implementing the second cycle of its health sector transformation plan, which basically outlines all the potential interventions and targets for a 5-year cycle. And that's part of the flagship initiative within that is the information revolution. So I would say Ethiopia is one of the early adopters of technology and understanding its impact in improving the health and well-being of population. And not only that, as its implementation plan, Ethiopia has also developed a digital health blueprint, which is a roadmap which dictates which kinds of lays force how the country should go in implementing digital health tools. It describes how we should be selecting the different platforms, how we should be customizing. It deals with ownership and sustainability. It deals with implementation fidelity, and also the different quality assurance techniques that should be followed at all levels within the healthcare system. So I think I brought these two documents to just show that this is absolutely important to have the higher level political buy-in, make sure that these interventions are highlighted in strategy and have a proper operationalization plan at national and subnational level. So I just took this figures was describing the toolkit, and why in the first place do we need digital health tools, digital tools? I think with digital health, I see a beautiful merger of digitization technology with health. So it's a kind of both. And whenever we talk about digital health, we should be starting with health problems, both at health systems level and at outcome levels, and reverse engineer the technology. So ultimately, we should be responding to a certain health systems need, and I think that's clearly described in the different booklets and tools produced by WHO as well. So this is a presentation of the Ethiopian healthcare system. Ethiopia follows a tiered healthcare system. We have our primary healthcare services anchored on rural community health extension workers, station-led health posts. We have health centers and primary hospitals. Secondary level of care is provided at general hospitals, and we have specialized services at tertiary level of healthcare. So with the next slide, I will be focusing on the different digital health interventions at the primary healthcare level, and as it's been rightly defined and outlined by the earlier presenters, that's where we, the first interface between a care provider and clients happen. So basically, this is the summary of my entire presentation. So I think sometimes we think that there is a confusion between digital health interventions and health information systems. I think for me, as someone who's been working in this space now for a few years, digital health is both a health service delivery package, and it's also simultaneously health systems intervention, because it has data capturing, data analysis, and decision-making support beyond primary healthcare units, and it also aids service delivery. We've been talking about, digitizing the different treatment guidelines, thereby ensuring standardization of care and compliance to care and treatment, and so forth. So in this slide, you can clearly see that Ethiopia, the flagship program in primary healthcare in Ethiopia is the health extension program. And at that level, Ethiopia has a platform which is built on ComCare called the Electronic Community Health Information System. The ECHIS tool is not only a health information systems tool, but it's basically a service aid, a clinical decision-making support tool. So it does both recording and reporting, and also assists service delivery by making sure that health extension workers deliver standardized care at the community level. And so far in Ethiopia, over 7,000 health posts have deployed the electronic community health information system. That's basically a catchment of over a third of the population. Over 20 million population has been registered electronically, and the health extension workers are using the electronic community health information system to do health promotion, prevention, and curative services. So far, the proactive med, maternal, neonatal, and child services are being provided using this community health intervention ECHIS tool. And as you know, you can see the continuum of service here. While the ECHIS does not only assist the health extension worker in providing standardized care, but also assists the referral system. There is an electronic referral system embedded within the electronic community health information system. And patients are automatically sent to the health center level, as you see. So this facilitates referral system and also facilitates quick intervention at the health center level. At the health center level, Ethiopia has now embarked on a journey of automating its public health centers using the electronic medical recording system. We don't have a good number of facilities which have implemented the electronic medical recording system. We've just completed the modeling exercise of deploying EMR in selected facilities. But going forward, there will be this electronic referral, as I said, at least in this model, facilities have significantly improved the delay in reference, and also has shown increases in terms of facilitating intervention. And there is not only the electronic medical system, but we have logistics management information system in the health centers as well. And this has been deployed in over 1,000 health centers in Ethiopia. So this is the logistics management information system used for managing inventory as the primary healthcare unit and giving the much necessary visualization to prescribers as to what is available and and what's not available at facility level. And it also serves a purpose of requesting critical commodities from upstream supply chain from national and regional medical stores, so that there is very fast replenishment of commodities at that level. So this digital health interventions has resulted in significant reduction of wastage. It has also maximized the availability of critical commodities at the health center levels. These learnings are being documented, and I think they should be available for wider circulation once completed. And again, with AMR, as you know, there is a reference to the primary hospital in our case, and we've also we have a clear roadmap infrastructure standard for kind of scaling up the electronic medical recording system. Next year alone, over 36 hospitals will be using the electronic medical recording system. And again, we have seen similar benefits at the hospital levels. Likewise, we've seen that there is significant increase in standard of care, client satisfaction, retention in care, because there are built-in notifications for both clients and providers, and also decrease in mortality. One beautiful thing about digitization is the empowerment of communities and patients, particularly at the community level with the ECHIS platform. There is an embedded notification, for example, for mothers to actually be notified about their subsequent ANC follow-ups. But again, beyond this, it has also features which includes, say, rescheduling appointments and that kind of stuff. And with that, we've seen an increase in adherence, particularly for family planning services and vaccination services. And as I said, this has been deployed in Ethiopia in over 7,000 health posts.
I think we've lost Dr. Abraham. There's Micah. Do you hear him?
Yes, I can hear you.
I do not.
Okay, do not hear him. Okay, I think we might have lost him. Okay, maybe, okay, yeah, I think he has dropped off. I think yeah, I see there are comments in the chat about a connection problem, but maybe we can actually move on to some of the discussions in the chat and see if Dr. Abraham is able to jump back on for further discussion. So there are a number of important questions raised in the chat that I think we can address more comprehensively. Maybe I'll start with the last one that Dr. Brieger just added around the differences in the use of digital technology in urban versus rural areas, and this also pertains to several questions. This also pertains to several other questions on how do we implement digital tools in spaces where there is lack of electricity or internet connection. So there are a few related questions on that. Welcome back, Dr. Abraham. I think I'm not sure how much of your presentation is left, but we lost you. Okay, perfect. So maybe you can finish that up and then we'll get back to the questions. Perfect.
Yeah, okay. So I think what are the lessons learned? I will be brief in 2 minutes. So I think the first thing is we usually start by selecting the technology and the applications that we want. But I think if we want to really make sure that we're solving real public health problems, both of the community and all other levels, it's very important the program service delivery problems and work our way backward in selecting the right technology, right infrastructure, right application whatsoever. So I think that's a lesson learned, because some of the applications are designed and then we're trying to see how they are impactful in terms of improving the overall health system. Second is verticalization of digital health interventions in primary healthcare versus integration to health service delivery package. So you have a health service delivery package, primary healthcare interventions, and we have digital health coming diagonally to actually improve health services. But once we know the impact, digital health should be packaged as part of the overall integrated health service delivery package. That way, it would be more sustainable. The ownership would be very good because program leads, providers would be part of that conversation, and ultimately we believe that it would also be cost efficient. Third is service education. Once we know that there is an endorsement at a higher up, we know that this is part of Ethiopia's healthcare system, and these are going to be nationalized. I think instead of going for in-service training, at least to make sure that the next cadre of healthcare workers should have the advantage of getting trained on the different digital health tools, and that could be tailored per professionals under consideration. Third is the project versus journey, because we sometimes think that we deploy digital tools and want to reap the dividends in months, perhaps in a couple of years. But I think with digital health, it's more of a journey than a project. So we know that there are new innovations. We know that the healthcare system itself evolves, and there are issues which come with digitization, including data security and so forth. So I think that communication should be clear. It's more of a journey than a project, and we've learned that because we want it very soon. Perhaps we want it yesterday, and sometimes it just kills the enthusiasm and the maturity of some of the tools that we deploy. The other is infrastructure that has been described, but I think, again, if we're going to go digital and if we really believe that digital tools actually improve, save lives, then they should be packaged with the overall infrastructure investment rather than, again, doing it particularly. And I think with when we use more digital tools at primary healthcare levels, then we're going to have individual data, and the issue of data security is becoming a huge issue, including in Ethiopia. And I think as a country, we should be prepared well ahead of time before we have problems related to data security. That's what I have. Thank you.
Great. Thank you, Dr. Abraham. So I think that's also a nice segue to our first question, which is really related to, I think, several concerns that have been raised around infrastructure and how can digital solutions thrive with the lack of electricity, internet connection, and sort of the differences that exist between urban and rural areas. I think Dr. Abraham's presentation talked briefly about the Ethiopian ECHIS system, which is the Digital Community Health Information Systems, where practically what's happening is community health workers are going door to door, gathering data in their on their tablet or app about the communities that they're providing services to, and the expectation is that this data is longitudinal, so we're able to see the record of a individual woman or individual client over time, and based on that, able to deliver appropriate services, are able to see data related to that on a digital dashboard. So I think, Dr. Abraham, you said that about a third of the country has now been, our healthcare providers, community health workers have been trained in the system, if I recall correctly. So I think that's a reflection of how some of the challenges associated with electricity, internet connection are being addressed in practice. There was also a comment about if a provider is offering services and electricity goes out, is the service interrupted? So I think all really valid concerns. There are also several solutions that are already underway and that various innovators have tested. So from my perspective, what we know is that a lot of the digital devices, and truly the strength of digital devices and why it has sort of been able to leapfrog the gaps in infrastructure, is because there is the possibility to sort of charge and not be connected to electricity at all points in time. So point of engagement during a clinical encounter, you're not dependent on electricity. And there are newer innovations in terms of providing alternate systems for charging devices. Similarly, data storage, there is the possibility to not be connected to 3G or to have access to data services, but be able to upload data to a cloud server asynchronously at a later time when you do have access. So there are lots of innovations around that. Maybe I'll open this up to the panelists, if they can come back on, maybe even turn on your cameras if you're able to, and talk to sort of what some of these very practical challenges in implementation are in countries, and also talk about how they're being addressed or what some of the innovations to address them are. Tigis, maybe you can go first.
Sure, I can go first, and I think it'd be great to hear from fellow panelists that are also in country. But I know that, both electricity and connectivity, as mentioned also through the chats, are a big issue when we talk about digital health. And we do see even not just for electronic recording, but even for telemedicine, it's actually a big concern, because if you don't have the right connectivity and you're not able to hear the diagnosis properly, that can really be a critical issue in the delivery of the services, or making sure that, in this lack of the physical contact, that the healthcare provider is actually able to make that decision. And I know that especially in the context of telemedicine, it's a big question that health workers have in terms of liability. If they misdiagnose something, like whose fault is it? What if they didn't hear something properly? Or what if there were issues in how the image was shared, et cetera? So the connectivity issue is definitely a big concern. I think there have been many different ways that people have tried to overcome this. So on the part about like the data collection and electronic recording, I think one of the major ways has been trying to figure out how systems can work offline. I think I saw that in the chat as well. And I know from even direct experience in some of the software development processes that is one of the main non-functional requirements. That's one of the main things that is requested is, can this work offline? And oftentimes it's also needs to work on a mobile device. So not use a desktop computer or a laptop, but actually use a mobile device that can run without electricity, and then linking it to solar power chargers. I've seen like mixed reviews on how well that works, but I know that these are some of the ways used to overcome that. And I think even on the telemedicine side, which I didn't talk about a lot in this presentation, but I know it comes up a lot. Having even like a health facility where an individual can go to the health facility, and then making that be the place in which they make the contact to the other health worker, so that it's not just individuals in their homes, but that they're actually linked into a place that may have better infrastructure and still get the benefits of the telemedicine service. So I think people have actually been very creative to try to make digital work. I think it's one of those areas where we see a lot of challenges, but people don't give up. Like no one has actually given up and said, no, I'm not doing digital health. There's too many barriers. Like I'm still waiting for that moment where people will say, this is just too overwhelming. But instead, people sometimes just want to work through those challenges, even though there's a lot of very big barriers to overcome in successfully implementing digital health. And we haven't really had a lot of large-scale digital health implementations, to be honest. I think despite the enthusiasm, these barriers always do come into play in limiting the scale and impact of the interventions.
Thank you. Thank you, Tigas. I think maybe it's worth adding that that digital is not always the solution to a problem. It's very relevant in a lot of contexts. I think it's very relevant in urban contexts. It's very relevant in contexts where government is building infrastructure. So I think Bangladesh, it provides a great sort of case study. Ethiopia too provides a great case study. There are policies and guidelines in place, basic infrastructure, a recognition of challenge of standards in place that public health sector can invest in to build on top of that. But in some places, it may not be. I remember one of our earliest studies in Ghana with a system called Motec, where they were sending SMS messages to women. We saw that it was timed and targeted SMS messages to women on their reproductive health journey, so prenatal to postpartum, and only about a sixth of the messages actually reached them in time and were opened over time. So I think that's really representative of the challenge. And maybe the first question should have been, is this an appropriate intervention? Or is another intervention likely to reach better coverage? Dr. Misha?
I'd like to add something with Tamrat. So it's from Bangladesh's experience. So, like BRAC Health and Nutrition Program. Under that, we have community health workers. So so we have in total like 43,000 community health workers all over the country. So these community health workers, they collect health information and provide basic healthcare services to households in villages and remote areas. So it's been a few years, I think. They introduced mobile financial services with them. So what happens, like before few years, I think before 2018, they would, after providing services, they would collect 100 taka or something, and end of the week, they have to go to the branch office to submit that money and also say like, okay, I've provided 12 NC 12 adolescent services, 5 services to old people, and this is how much I have collected. But after introducing MFS, what they do is the app is designed in such a way, like as soon as I provide, me being a Shasta Shabika or community health worker, after providing ANC service, I'll just transfer that money I have collected in cash. I would have some money on my mobile financial service, and I'll send that money to this BRAC account with the reference code that refers to what type of services I provided. So, in the portal, they have the record there, like, okay, so Misha provided 12 ANC this week and this and that. So, which is very time and cost effective. They don't have to travel. They don't have to do the math manually. So it's not like the whole process is digitized, but even a part of digitizing a part of health service delivery can, increase effectiveness. So I just wanted to add the BRAC example. Thank you.
Great, Dr. Ibrahim, is there any insights from your perspective, especially with the ECHIS system that you described?
Yeah. And I think infrastructure, I don't think it's something that would go away anytime soon. So if we truly believe that, as you said, digital health tools are not solutions to every problem that we have, but they are specifically designed to solve certain public health problems, system level problems. And in Ethiopia, with ECHIS, we're deploying ECHIS using tablets. And yes, you need a power station to charge your tablets. Electricity is very important, but at least it will give you 8-10 hours of service without electricity to actually use tablets and station desktops. Not only that, there are also backup solar charging batteries that are given to the community health workers. Again, majority of the deployment was in agrarian settings, and agrarian settings are relatively have better infrastructure. Again, this compared to the pastoral setting. It's just last year that we ventured into that setting, and the problems just got worse. Yeah. So I think I still think that there are solutions, a way around it, and again, with further with development, we think that majority of this would continue to get electricity, and we've now seen battery solar panels which could actually serve, say, 2 days, 3 days. And there are pilots in schools right now with a technology called solar spell, for example. So I believe there are solutions, but ultimately the remedy will be making sure that power is accessible. But for now, there is a way to work around it. Those are the challenge.
I think if I may offer a sort of a gross generalization is that in a lot of urban areas, we see, like in several Western countries and several sort of also South Asian countries, we see a trend towards use of healthcare apps. And so those are direct to client interventions, and they are more likely to have better adoption in urban areas. Whereas in a lot of rural areas where infrastructure is often more limited, digital interventions can be mediated through healthcare workers, because that's an area that we can more closely monitor. So I'll move us on to our next question. I see several questions related to this in the Q&A, is related to the engagement with private sector and how they might contribute to the development of the digital health ecosystem, to innovation in the space of digital systems, and where they might be most effective in partnering with the government to strengthen digital health services. Because maybe we can go around in the same way. And
yeah, I think definitely, I mean, to start, a lot of the developers creating these digital tools are from the private sector. So I think already you start from a private sector engagement, even if that's not what was intended with the private sector engagement. But it is something, I think digital health is kind of unique in public health, because you do have business models of software development teams that are relying on, the use of the app. And I think that also requires its own discussion of, how, what are the business models of these software development companies? Some of the private sector companies that are being engaged aren't actually available in the country, and they have models in which, maybe part of their team is in country and part overseas, or maybe completely all overseas. So there's that level of, with the software development team, that level of engagement. In terms of the other big, private sector engagement that needs to happen is also with the mobile network operators. And I saw a message earlier about, there's not enough emphasis on health promotion, but I think, one of the first initial uses of mHealth was in like a lot of the SMS-based applications, like such as what Smisha mentioned at the program in Ghana and everywhere. I mean, I think everybody was really encouraged by, oh, how can we send messages for everything? And that, comes to a point when the project is over and you have to go back to the mobile network operator and say, okay, so are you going to give me discounted rates on the messages? Will you be able to pay for some of it? And so I think, and they have their own corporate models of they need to, this is a network operator, so they can't be as altruistic as we'd like to be in public health and say, yeah, we'll send messages for free. So there needs to be actually some type of, negotiation and engagement that happens on that. So software development side, the actual network side. And then I think increasingly, some of the questions I get actually from colleagues at WHO in the PHC unit is a lot of the work that WHO is doing on digital health seems to be very much geared at public sector health facilities. And what about private sector health facilities? Because I think, maybe in Bangladesh with the BRAC example, if that's considered as private sector, I'm not sure. But I know in WHO's emphasis is always on like what the facilities that governments have and really strengthening that. But then also realizing that healthcare services are being delivered through pharmacies that may be in the private sector. They're being delivered at private sector health facilities. And how do we also make sure that we don't leave them out of the DHIS2 reporting, because we miss out a lot of how services are being delivered if those that are in the private sector don't have to conform to the certain standards of digital tools, as well as we all the DACs, smart guidelines, we're just really gearing it towards these public facilities. But what about the EMRs that are at the private facilities? How do we work with them? And I think those are, in my mind, the three areas of where the private sector engagement questions really come up, and different ways of dealing with them as well. Over.
Farzana?
Well, I'll just like to add that from Bangladesh's example, in the private sector, there are many apps available. Still, there are some organization designing specific apps for specific kind of health services. But as I mentioned during my presentation, there is a lack of regulation. So that's something we have to keep in mind. For example, during a study, our study on SRHR, on adolescent and a young male, like 15 to 24 years old men. So when we looked at how they access SRH information using digital technology, so we saw that most of them, like 90% of them, they have access to mobile, and 85% of them, they use mobile for entertainment purposes. But we don't have information on how many of them use it for health information. But during the study, what we saw that a high percentage of them, I don't remember how much, but they use YouTube channels for health information, SRH health information, YouTube channels and Facebook social media platforms. And there was this one YouTube channel that was very popular among them throughout the country. So that's where Dr. Farhana provides, SRHR information. Nobody knows who Dr. Farhana is, even whether like nobody knows if she's an actual doctor. Yeah. But she's providing, like strange SRHR information, like if this is happening, that this means you have this STD, you drink this juice of fruit or something. So it's and they are following those, right? because nobody talks about SRHR, because it's considered a taboo when it comes to Bangladesh, and especially for male, because of their masculinity traits and stuff. They don't want to admit that we might have SRHR problems. So digital space has the potential to address these issues. As I mentioned, like when it comes to SRHR, you can provide information and make sure that someone can ask questions anonymously. So, because I don't want to reveal my identity, right? But then again, this also needs to be regulated, that accurate information is being provided. So this is where private organized healthcare provider facilities can play a role, but then again, the regulation has to come from the government. Because yeah, thank you.
Yeah, lots of great points, Farzana. I think one of the first things that you said is also there are lots of private entities building apps, right? And so one distinction to make, and there are some questions about this, is when apps are being built for consumers, for direct-to-consumer marketing, it's a different ecosystem, right? But when apps are being built for public sector consumption, there are different issues. When apps are being built for public sector consumption, we are interested in issues of interoperability, in following standards, in following, of course, in following evidence in all cases, but interoperability and standards become really critical because and I see some questions around this, around, if there are standards by government, won't it hinder innovation? But the reason for standards is if as a patient, I go to one health facility and the next, in an ideal healthcare scenario, I'd like my healthcare records to be available at both facilities. And that's why we want the healthcare system, at least the public healthcare system, to have some kind of a digital record that can be shared between providers. That's ideal. Now, in case of direct-to-consumer marketing, I think the considerations are really different. And I think, Farzana, you raised some excellent points around misinformation, validation. There is even in the US, there are issues around that because the FDA does not regulate how health content is delivered, and so through apps, and so there's a lot of health apps that are marketed as entertainment, and they can share information that's not evidence-based, and that's really a very, very different ecosystem where considerations are really quite different. A lot of need for regulations. We don't have the answers to a lot of them. So, Dr. Ibrahim, do you have a perspective from Ethiopia around any of this?
So as you know, Ethiopia has not, we have examples, but it's a country where we don't have good competitive private sector. But I looked at the question, and I think there are two versions of private sector involvement. There are private sectors which are providing care and services, and they also need digital tools. So whatever we talked about in HSCP and digital health blueprint is basically for public hospitals, and over 80% of care and treatment in Ethiopia is basically given through public outlets. But for routine health management information systems, it's now part of our guideline to actually enforce private facilities to report through the national DHIS2 platform for their routine health management information system, so that clients getting their services, the private facilities, are also accounted for when setting policies, priorities, and interventions. So that's one side of the story. The other side is actually in the technology space, the digital space. So far, we only have a single telecom provider in Ethiopia, but the private sector has been encouraged to be actively engaged in innovation and the adoption of digital technology. Majority of the applications, particularly for clients, are developed by the private sector. And we now have mushrooming facilities providing telemedicine, teleradiology, teledermatology services in addition to other urban settings. So they basically are setting, are becoming testimonies to how we should be implementing telemedicine, teleradiology services in public facilities. So innovation, adoption, and basically showing the way is where we see private sector engagement. The other one is infrastructure support. So we talked about the primary investment, but from what we have seen, there has not been as much problem in investing, first-time investment for getting all the gadget infrastructure support. The problem has always been in maintaining this huge level. So we see the private sector giving readily available grassroots infrastructure support. This could be maintenance, troubleshooting, and that kind of stuff. And the sector has commissioned over 200 enterprises to actually give grassroots support in maintaining infrastructure, troubleshooting, and giving minimal support on-job training for the health service to do minimal visualizations and data analysis. That's the experience from Ethiopia. Thank you.
Great. Thank you, Dr. Ibrahim. I think we're approaching the end of the time. I'm still looking at the questions in the chat. I'm afraid we've not been able to address all of them, but I hope that we've sort of conveyed some of the potential, and always also talked through where the limitations are, though with some solutions on the horizon, a lot of emerging evidence and a lot of promise. So I think I believe the panelists are open to being contacted, but if you'd like to reach out to anybody, IPHC can help facilitate that. But if it's okay, Micah, should we wrap up? And
yes, let's do that. And yeah, thank you so much. This has been a fantastic discussion, and we've covered so much ground. And I think it really shows how digital health really can potentially contribute across so many different aspects of the primary healthcare system, but also with many of the sort of caveats and nuances that you all have teased out. So this is fantastic. I don't know, Smisha, if you want to say any further closing words or anything, but yeah, this has been really phenomenal.
Yeah, perhaps just in closing, I would say that there are lots of reference materials for folks who are interested in digital health that can be used as a starting point to understand the details better. I think we went into some technical, details today, but really, digital health in and of itself is going to be the way of the future. There will not be health programs without a digital component. So we should not think of digital as sort of a vertical stream in and of itself. It's very much a small but critical portion of the future of primary healthcare. And we should not think of it as a whole. It is a small sum that, a small part of the whole. And there is a lot of potential, but it cannot exist independently without the necessary ecosystem, which we've been able to discuss today. So thank you all for your participation, and yeah, good evening and good night, everyone.
Wonderful. Thank you so much, Smisha, for moderating and bringing so many of these important points forward and pulling things together. Thank you to all of the panelists for the wonderful and really informative presentations and different perspectives. We do often get questions either that we weren't able to answer during the session or that come in afterwards. So we'll definitely keep in touch with all of you. Thank you to all of the participants for joining, for participating actively, bringing your perspectives and your questions to the discussion. If there's something we weren't able to get to that you'd really like to know more about, as Smisha said, we can facilitate connections with the panel, and also there are a lot more resources that can be shared. So please feel free to reach out to the Institute and all of the collaborators. And on behalf of the Institute and also Hopkins, I'd like to just say thank you and hope that you all will join us for future webinars as well. You should be hearing more from the Institute about what the coming topics will be, and hope to see you again soon. So thank you all. Have a wonderful rest of the day, and looking forward to being in touch.
Thank you.
Bye-bye.